Hi, Shaheenah. How are you? Good evening.
Hi.
Hello. Hi. Hi.
So, good evening, good morning, and good night from everyone across the globe that's joining us for this edition of the EIOC Journal Club. Today, we're going to be talking about the use of bevacizumab and PARP inhibitors as maintenance therapy for patients with advanced ovarian cancer. My name is Shaheenah Dawood, and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates, where it's perfectly safe and we're all functioning as normal, in case you were asking for an update. Today I'm joined by some spectacular faculty, both international and regional. We're very honored to have Kathleen Moore here all the way from the USA. Kathleen, would you like to introduce yourself?
Hi, everyone. Number one, I'm so glad that things are fine there. So I was worried. But I'm Kathleen Moore. I'm the Deputy Director and Director of Phase 1 Clinical Research at the Fred and Pamela Buffett Cancer Center in Omaha, Nebraska. I moved from Oklahoma about 2 months ago. So I'm in a new place and I'm happy to be here.
Thank you, Kathleen. Hala, please everyone put their videos on so I can see you. Hala? Yes,
Yes.
introduce
Yes.
yourself.
Yes. Dr. Hala Abdellatif. I'm a medical oncologist in Virgin Medical City Cancer Institute.
Thank you, Hala. I think Dima
Thank
has
you.
yet to join. So Sina, maybe you can put your video on and introduce yourself. Sina? I think she's switched off. Dr. Ahmed. Dr. Ahmed Shams, you're muted. Can you please introduce yourself? You're muted, Dr. Ahmed. Yes. Okay.
Yes, good evening. Good evening, everybody. Nice to meet you all. I'm Dr. Ahmed Shams, medical oncologist at KCC and Jabbar Hospital in Kuwait.
Dima, can you introduce yourself? You're muted, Dima. Dima, we can't hear you. All right, so while we wait for Dima to get her technical difficulties overcome, we'll get Aref. Aref, can you please
Hi
introduce
everyone.
yourself?
Hi everyone. Hope you are fine. I'm Dr. Aref. I'm medical oncologist from Sultan Qaboos Cancer Center, Oman, and actually I'm working since 4 or 5 years in the gynae program. So I'm treating only gynae cancers.
Thank you. And I think Sinam has some technical difficulty. Oh, Sinam, you're here. Please introduce
Yes, I'm
yourself.
here. Sorry, I disconnected. So I'm Dr. Shaheenah Makbash from Bahrain Oncology Center, medical oncology consultant. And I'm originally from Turkey, and I'm here in Bahrain for now 1.5 hours. And I'm generally interested in breast and gynecological cancers.
Thank you. So without further ado, I'm going to share my slides. I hope everyone can see my slides. Like I said, we're going to be talking about first-line maintenance strategies in patients with advanced ovarian cancer, specifically focusing on bevacizumab and PARP inhibitors. These are my disclosures. And if anyone would like to get in touch with me offline and network, I'd highly encourage you to scan the QR code. So I'm going to start with a case and really work through that case and tear apart the data and really get insights from all of you. So this is a 45-year-old woman. She's married with 2 children. Her mother had breast cancer at the age of 70. She presents with increasing abdominal girth. She's found to have ascites and omental caking. Her CA125 is 700. Her CEA is 2. And her acidic fluid is drained, and the cytology shows high-grade serious
Shaheenah,
carcinoma. Yes.
your voice has echo or just from my side?
I think it's just from your
for
side.
you.
You need to mute yourself, Dima.
Yeah, I think it's you. She's pretty clear, at least for
Yeah.
me.
Okay, thank you. So the
Yeah.
acidic fluid is drained. Cytology shows high-grade serous carcinoma, and an omental biopsy shows also high-grade serous carcinoma. And so at this point, before I deep dive into the data, one of the questions that we ask ourselves is, would you proceed with upfront surgery versus chemotherapy alone? And the reason why I ask this question is we do have oldish data that was published in the New England Journal of Medicine that looked at neoadjuvant chemotherapy versus primary debulking surgery. I believe this was a GOG study, which randomized patients to primary surgery versus primary chemotherapy. And at least visually, I don't seem to see any difference between the two groups of patients. But last year at ASCO, we did see the results of the TRUST study, which actually created some controversy in the oncology community, especially the community oncology community. The TRUST trial actually took patients with stage 3B, stage 3C, or 4A or 4B ovarian cancer or primary peritoneal cancer, randomizing them to either primary cytoreductive surgery or neoadjuvant chemotherapy followed by interval cytoreductive surgery. And the primary endpoint of the study was overall survival. And you can see that in terms of the progression-free survival in the intent to treat population, it seemed to favor the group of patients who were getting primary debulking surgery versus neoadjuvant chemotherapy. You can see the blue lines here, although there seems to be some form of a crossover happening right at the top of the curves. You can see that the restricted mean PFS time improved from 26 months to 31.7 months. And when you look at the overall survival here in the intent to treat population, overall it seems to favor the primary debulking group of patients. But again, you are seeing that little bit of an overlap right at the top where it seems to be favoring the neoadjuvant group of patients. Now, specifically, our patient had stage 3 cancer. So I looked at the pre-specified exploratory subgroup analysis. And again, in that stage 3 subgroup of patients, again, you're seeing primary debulking surgery favoring the group of patients compared to neoadjuvant chemotherapy. Now, I know, Kathleen, in the US, I think there is, like a divide amongst whether you do primary versus neoadjuvant. I can tell you that we have this discussion all the time in our MDT and our gynae-onc when they see patients with extensive omental caking, ascites. They always say, give some chemo first, reduce that burden of disease so we can do a better job at optimal debulking. But with the results of the GOG as well as the TRUST trial, what are your thoughts?
I think, so we have so many phase 3 studies telling us there's no difference, but yet we are surgeons, and so we still argue about this. So we have to say that all of the studies that have been done thus far, every single one of them does not support primary cytoreduction as superior. Like, we just have to say that out front. Then we can talk about it. So surgical trials are really difficult to do because of all the factors we could talk about, effort that goes in. Sometimes surgeons change what they do based on, at least in the United States, if you're at Memorial Sloan Kettering, they're going to have 4 surgeons in the room doing this massive debulking and then go to their completely supported intensive surgical ICU unit where there's all the support to get the patient through what can be a very complicated postoperative course. Many places in the US don't have that. So you can have a great surgeon in a place that, doesn't have that sort of SICU capability, and they do change what they do because probably that little crossover that you saw, maybe the kind of, it's probably many things, but it could be the post-op complications, because we know that significant post-op complications and delays in chemo do impact overall mortality. So there's this correlation with that. That being said, for this patient, depending on, she's 45. So for me, I would want to give her the benefit of the doubt, because I really do, in my heart of hearts, believe for stage 3, someone that can get to truly no gross residual is going to do better than somebody that I start with neoadjuvant chemotherapy. So a young patient who's maybe going to have a BRCA mutation, I would at least go to the OR and put a laparoscope in and look. And your consultants, oncologists are right. The majority of the time, you're going to put that scope in when they have a lot of ascites and there's just miliary disease everywhere, and you can't get that out. And so just stop, don't cause harm, and start chemo. I agree with that. But sometimes you'll put a scope in and it's all in the omentum. And it's just this massive omental cake, and the peritoneum is like largely pristine, or maybe a few things that you can just pick off, and you can get that person side reduced to no gross residual for real. I think people lie sometimes, but like for real. And I think she's going to do better. So I actually favor looking. I like to put a scope in and look and really assess what's there. And if I can do it without undue risk of significant side effects, like it's going to take me 3 bowel resections to get this, that's probably not anymore a smart thing to do. But sometimes you're surprised and you get it out. So I still think there's some individualization here that needs to happen between medical oncologists and GYN oncologists or the surgical oncologists to make sure that we're individualizing best for each patient. And I think primary side reduction probably makes a lot of sense for some, but probably
But
not for
all.
most.
Yeah, but not all. How do you explain this change in the overall survival curves when it comes to, primary cytoreduction versus neoadjuvant? You see that benefit for neoadjuvant right at the top of the curve, and then it becomes less beneficial.
Yeah, that's what I think. I don't know that I know all the answers to this, but I do wonder. I mean, that's kind of that separation's out in that first like 12 to 18 months.
Exactly.
And there is data. I'm sure there's data in Europe as well, but in the US, there's data that is pretty consistent that when you do these big primary side reductions and we have 30-day post-op mortality, so you're going to see that like those patients have died, so that's going to impact your overall survival. But then you have patients who had significant postoperative complications and prolonged hospital stays, or they had an anastomotic leak or an infection or pancreatic tail leak, these things that when they happen, patients end up in the hospital for many weeks and then going to like rehabilitation centers. And so their chemotherapy is significantly delayed, like beyond 12 weeks. That impacts overall survival. And that's going to shorten that overall survival into that 1 to 2 year range. And so that may be some of what's driving this is primary side reduction in stage 4, for example, which I think most of us think now is not a good idea. If they have complications and they're delayed starting their chemo, chemo's really is, surgery is important, but chemo is really the most important. So if you delay someone's chemo, that's going to impact their OS. So I do wonder if some of that is just a reflection of people who had significant complications post, and they did have complications on the TRUST study. They outlined them pretty clearly.
Yeah.
And then that impacted their, frailty, their reserve. I think there's just a cost of complications on patients' ability to, make it through everything and live, right? You kind of just drain some of their life force when we have a big complication. So that's my suspicion there, but it'd be better to have the PI on the call to tell us what he thinks. He's a smart guy.
So you don't think that the TRUST trial has impacted your practice that much? You're still individualizing and discussing each case and perhaps scoping those patients to try and see who is going to get primary debulking versus neoadjuvant chemotherapy.
We really are. I would say that, I wouldn't say it didn't impact us because I trained at a very surgically aggressive place, now 23 years ago. It's been a long time. But, when we were trained, my surgical mentors who are amazing surgeons and amazing anatomists, I remember this as a fellow. They would say, if I was going to do neoadjuvant, they're like, oh, you're just giving up on her. You don't care about her. Like they'd say things like that, like you're not going to try. And so like that was the mentality that at least I came from. And there's centers like that in the US. And then there's centers in the US that were always doing neoadjuvant. So there was this big divide. So I do think those of us that were like really biased towards surgery, the TRUST study was the one we were waiting to see. Like this was the study we were going to believe. And I do think we believe it. So I do think it's impacted us. We use far more neoadjuvant chemotherapy than we ever have. I just think there are still questions. So as everyone on the calls knows, we design clinical trials in a way that hopefully answers a question, but also makes the clinical trial feasible. And so in this clinical trial, you would have liked to have designed and fully powered stage 3 and stage 4, for example. You would have liked to fully power those, so you really could have looked separately, but that would have been an enormous study. These surgical studies are hard to do. No one's funding them. Like Merck's not funding this. Like, so you sort of have to do the trial that you can do, and then you have to apply the results to the real world. And I think there's still some unanswered questions from trust that make me a little nervous to just say everybody gets neoadjuvant now. And maybe I'm wrong, and I should just be doing that, but we are still individualizing. Probably 30%, I think, are getting primary site reduction now, 30 to 40. And the rest are neoadjuvant. I think it's also impacted us because I used to feel really bad about that. Like I would feel really bad. Like I don't like neoadjuvant. And now I'm like, you've proven it to me in stage 4. You've proven it to me in patients who have, patients who have just biologically aggressive disease where you're having to do 3 bowel resections and a splenectomy and, a diaphragm resection to get it out. I used to do that. I mean, that's probably harming a patient.
Yeah.
So I feel less sad about that now than I used to. And I think that's important, because you don't want to do anything you don't want to hurt people with what you do, but you don't want to hurt people with what you don't do either. And so there's always been this tension of how hard to go.
Sinam, this patient comes to your clinic, and are there any further tests that you want to do for this patient? The decision's been made. She's actually going to go for surgery. But are there any further tests that you want to do for this patient at this period of time?
Yani sure. I will do germline testing for BRCA1/2, and if negative, HRD testing should be done. It won't change the primary treatment actually, but it will guide me after the primary treatment.
So that's actually quite interesting. Dr. Aref, do you do sequential testing, germline, and then somatic? Or do you start off with somatic and germline together? Or do you just start off with somatic and only if you pick up something, then you go on to germline? Because I think that's very important. I can tell you in my practice, do it dual.
So in my practice, when I'm seeing the patient in the OPT, I always do germline because germline will send only blood. It's very easy to do it, and I will get the result in 2 weeks in my center. So I will know if there is germline mutation, yes or no. But I'm doing as well NJS for all patient, and we send HRD. But if patient is BRCA germline, so the response is easy. She's already HRD by being BRCA, and
Absolutely.
But I'm doing this. I want to know which tumor I am dealing with since the beginning.
Perfect. So that's my next question. Dima, how are you doing it at your center? Is HRD testing done as a reflex test, or are you specifically having to request for it? I can tell you at my center, it's not reflex. Any ovarian cancer patient that comes to me, I tend to do dual germline testing and somatic testing at the same time, but it's not reflex. So what are you guys doing at your end? Dima, you need to unmute yourself. Yes.
So, at my center, definitely everybody, like you said, get the germline testing, and if they are negative, then we get the HRD testing. That's how we do it. It's not
I'm curious, Kathleen. I've always been an advocate of doing it together if cost is not an issue. And if cost is an issue, I think it's better to do somatic rather than doing germline. But what are your thoughts here?
Yeah, there's so many ways to do this. And my truthful answer is do whatever works for your institution as long as we're being consistent. So, so some places like Canada, for example, Canada is a great job and they have, universal health care, so they can't pay for everything. Okay. But what they do is somatic testing on everyone right out of the gate. So 100% of it's reflex. 100% of patients with ovarian cancer get somatic testing, and then they reflex as a reflex, and then they reflex to germline if they find a BRCA. So they're at least covering BRCA, which is critical, and then they can do cascade testing. So are they missing some? Yes. Are they missing fewer than in the US where it's dependent on a physician to like individually order it every single time? No, they're probably doing a better job, than we are because it relies on, there's no reflex testing. So you kind of have to do what works for your system. But I think the focus on identifying the most patients with BRCA is critical so that you can get them a PARP, number one, but number two, so you can figure out who's germline and then help their family members get tested. And then if they have germline, you can hopefully prevent them from having this disease ever, which is the most important thing I think we can do. If you can do everything, I do everything. So, but I'm in the US where we can do whatever we want. Like no one tells me I can't do anything. So I send everything. I'm like, doctors, how do I say your last name? Is Zribi? Zribi? How do I say that? Zribi?
Zribi, Aref, Zribi, yes.
Zribi.
Yes.
Zribi.
Yeah.
Okay. Dr. Zribi, I do what he does. I do
Okay.
germline, and then I send next-gen sequencing, and the next-gen sequencing panel that I send has HRD built into it. So I
Yes.
like everything. I like to know all the things up front so I can think about what she has and make my plan. But I don't need all those things up front. Like I don't really need it all up front, but I like to have it. So that's what I do.
Absolutely. I like to have all the information as well. And that's why we send germline and we send NGS and we just get all the information, including IHC for everything.
We do
So
too. We do the whole thing. And then I re-biopsy it later. So I mean,
exactly.
I'm just like always gathering information,
Yes.
even if I don't need it. So I'm always really careful when I'm talking with people just to make sure you don't have to do that. Like right now in the front line, you need to know BRCA, and depending on authorization for PARP, in the US, I have to know HRD now because we don't have authorization for PARP inhibitor in HRD test negative, which I don't think is a terrible thing, but I have to know. So I have to know that. And then I like to know HER2 and folate and cyclin E because that makes me think about things. But I don't need them yet. So there's cost ramifications for these tests in different parts of the world and to our patients. And so I just want to be clear that there's must-haves and then there's intellectually stimulating knowledge. Those can be different things.
Okay, so this lady has upfront surgery with optimal debulking and is found to have a somatic, not a germline, but she has a somatic BRCA mutation. So Dr. Ahmed Shams, let me pick on you. Would you consider adding bevacizumab to the chemotherapy in this particular patient? You're muted.
For sure, yes. I think it's better to start with adding bevacizumab for such a patient. That's what I would add for her benefit, يعني, in the future wise.
Okay, Dr. Sinam, what are your thoughts here? Would you add bevacizumab for this patient?
I'm not so 100% in bevacizumab side. Yani, maybe I can go with olaparib only.
Okay. All right. I mean, Kathleen, let me ask you a question that's not related to primary debulking, but say suppose this patient was scoped and there was just too much disease and the surgeon backs out and says, look, this patient needs neoadjuvant chemotherapy. Would you give BEV chemo in that neoadjuvant setting, or would you reserve the BEV for the post-op setting? Because there's always this discussion with when we should place the BEV. For me, if a patient is very advanced, I feel like, and I don't feel like, I think the data does support, you get a higher response rate with BEV plus chemotherapy. But what are your thoughts here? Would you give it neoadjuvant?
I do. I do cycle. So if I'm not going to do primary site reduction, especially this patient who had a lot of ascites, I'm adding it with cycle 1 and 2, and then probably thinking about when we're going to do interval surgery, either after cycle 3 or 4, because you want to hold the bevacizumab, that preceding cycle. So I'm usually giving it the first 2 cycles, and then I'm not usually giving it cycle 3. And then if I don't decide to operate, it might be those 2 cycles don't get it. And then I don't give it the cycle after surgery, and I'll restart it subsequent to that as long as there's no complications. So I do use it. I think there's quite a bit of data that shows that it's safe. I know in many parts of Europe, they don't start it till post-interval cytoreduction. So I think there's a lot of equipoise here to do it. So yeah, I think it's safe to do in this patient. It's going to help her feel better faster. Like it's going to dry up that ascites, and she's going to feel better by the end of cycle 1 probably. So I like it for that reason. But I do think you have to be a little careful, because sometimes, I mean, I don't know how patients present there, but here in rural parts of the US, sometimes patients present to us and they've had symptoms for months and months, and their disease is so massive. And they have bowel involvement. So I'm pretty conservative around bevacizumab. I will also say, because the last thing I want is a bowel perf,
Exactly.
which is, and I think it's in the clinical trials in the frontline setting was pretty low. It was like 1 to 2%, but in our practices here, we just see patients coming in with really, really advanced disease, and they're very sick. So we're a little more conservative with it here, just because it doesn't improve overall survival, and we don't want a catastrophic complication. But I do like it in the neoadjuvant setting. I'm just really careful.
Okay. So we've talked about that. So now let's just look at some of the data looking at bevacizumab in patients with ovarian cancer. We've got the GOG 218 study that took newly diagnosed patients, stage 3 and stage 4, randomized to get paclitaxel carbo or paclitaxel carbo plus BEV. A lot of these patients had primary optimal debulking surgery. Then you had the ICON 7 study, again, similarly designed, randomized to get chemo or chemo plus bevacizumab. And you can see that in both the studies, the GOG 218 and the ICON 7, there was an improvement in the progression-free survival. There was no difference in the overall survival, but an exploratory subgroup analysis actually showed that there was an improvement in overall survival, especially in those patients who are considered high risk, GOG 218 specifically in the stage 4 patients, and in the ICON 7, those patients considered high risk. And it was based on this data that in 2018, the FDA actually approved the combination of chemo plus BEV followed by maintenance BEV in those patients stage 3 and stage 4 ovarian cancer. And you can see the GOG 218 ascites actually predicted treatment benefit for bevacizumab. That's something that we were just discussing as well. You can see the PFS in patients with ascites and the OS in patients with ascites was improved with the addition of BEV. Now, Dima, what do you do with BEV in patients with your high risk and low risk stage 3 and stage 4 ovarian cancer? Where do you actually place BEV for these patients?
So again, based on the data you presented, this is very old study. We all use the bevacizumab upfront, like Dr. Moore said, before surgery, if the patient is very high risk. If they have ascites or anything, we always try to use it, stop it last cycle 3, wait for another 3 weeks, then go with surgery. This is the standard. And if they are PARP mutated, we continue olaparib. If they are not, based on the HRD, this is actually how I use it. If the patient is low risk, then sometimes we don't use the Avastin. You have to continue again for 15 to 18 months based on which study you want to use. But then if you don't use it, sometimes if it's a very low risk disease, minimal, sometimes, it's a discussion at the MDT whether we need to use it, because again, there is no great overall survival benefit. That's what we do. It's a discussion.
All right. So remember, this patient had a BRCA somatic mutation. We've got a number of phase 3 clinical trials that have looked at using a PARP inhibitor in that maintenance setting. You've got the SOLO-1 study that randomized patients to olaparib versus placebo in those patients with a germline BRCA mutation. The PRIMA was niraparib plus placebo irrespective of BRCA. PAOLO was olaparib plus BEV versus placebo plus BEV, again, not selected for BRCA. And ATHENA was rucaparib versus placebo, not selected for BRCA. And you can see in all these studies, adding a PARP inhibitor did improve the PFS in that first-line maintenance setting. Now, going to SOLO-1, just recapping that data, you can see a very nice separation in the Kaplan-Meier curves very, very early on, where you see patients who are receiving olaparib. Now, remember, these were germline mutation positive patients, where you have an almost 70% reduction in the risk of progression of disease, and every subgroup is actually benefiting. Then you had the Palo 1. Remember, these patients were unselected for BRCA, and they were randomized to olaparib plus BEV versus BEV plus placebo. And the primary endpoint here again was investigator-assessed PFS. And what you see essentially is the PFS in the whole cohort, nice improvement in the PFS with the use of olaparib plus BEV versus in the HRD cohort, an even bigger separation, the Kaplan-Meier curves, very early separation. You can see a 67% reduction in the risk of progression of disease. Kathleen, maybe I can ask you this question, because when Paolo was first designed, and I'm really looking at the trial design here, it left so many unanswered questions the way it was designed. It was designed to see olaparib plus BEV is better than BEV alone, but what about olaparib alone? Why was that third arm not included in this particular trial? I know it was unselected for BRCA, but we'd already had some data telling us that PARP does work in these patients who don't have a BRCA mutation. So what are your thoughts here?
Well, remember, right, this is the missing arm. So a couple of things about Paolo 1. Number one, Paolo 1 was originally an investigator-initiated trial led by Isabelle Ray-Coukard that became a registration-enabling study after the fact. That's really unusual. It was never designed, powered, or designed to be a registration-enabling trial. It was really a trial designed because in Europe, it's different bevacizumab use. This was driven by bevacizumab use. In many parts of Europe, you can only use it in frontline. And the study that was still ongoing at the time this launched was Solo 1. When this launched, Solo 1 had not read out. Neither had Nova, neither had Prima. And so they designed this trial in an era before we had seen the PARP maintenance data. And they wanted a study that let them use BEV in the only place they could use BEV, which is frontline. So they did BEV because that was their standard of care, BEV olaparib. And then Solo 1 read out, but when Solo 1 read out, this study was done accruing. Like, you couldn't amend it at that point. It was sort of done, and here are the results. And it kind of came out at the same time as Prima and a little bit before Athena. So they never, had they known the power of PARP in HRD, and HRD wasn't even an endpoint in this study. That was exploratory in Paolo.
Absolutely.
So when it was designed, we didn't have the data yet. By the time we had the data, all the patients had accrued to the study and were like on maintenance, and there was nothing to do to fix it. Like, it was sort of done, and these were the results. And so it kind of is what it is at this point, a difficult to interpret study, but it gives us data on the safety of the combination, really, outside of BRCA. But
So
that's why.
Then you can see that in those patients HRD positive but BRCA wild type disease, if you're looking at Prima, which looked at niraparib, or Athena, which looked at rucaparib, or Paolo, which looked at obviously olaparib plus BEV, in that HRD positive BRCA wild type, these patients are actually doing very, very well. But again, we don't know what the exact role of bevacizumab is there. Then you see the 5-year follow-up of Solo 1, and you can see the PFS. It doesn't matter whether you're in the higher risk group or in the lower risk group, adding a PARP inhibitor does work, and it works very well. And similarly, in Paolo, the lower risk and higher risk group, BEV plus olaparib is better than BEV alone, irrespective of that risk status. And then we saw, of course, the overall survival at 7 years for Solo 1, and we saw an improvement in terms of overall survival. You can see 75.2 months in the placebo arm versus not reached in the olaparib containing alone arm. And then you can see in the Paolo 1 study, the final OS, you can see that using olaparib plus BEV trumped using placebo plus BEV, And that translated into an almost 38% reduction in the risk of death from disease when you used the combo. So my first voting question to everyone, do you believe all patients with the BRCA mutation should receive a PARP inhibitor? I think unanimously you should all say yes. Please do not say no for this particular question. Aref, what are your thoughts here? Do you believe all patients with a BRCA mutation should receive a PARP inhibitor?
Yes, not 100%, 1000%.
But Kathleen, let me tweak it slightly for you. If a patient, and the approvals are only for stage 3 and stage 4, but what if a patient has a high risk, say stage 2 disease, and you just want to give a PARP inhibitor to this patient, the patient has a BRCA mutation, would you do it?
Oh, yeah, I would absolutely do it. I mean, I have to be honest, I'm a little biased. I don't really believe in stage 2 ovarian cancer. I mean, it's just nonsense, really. Like there's no magic wall at the pelvis
Okay.
that sells out. Like it's just a silly thing. So if it's stage 2, that's a high risk tumor. We've known that, from the few studies we've done in early stage disease where we used to lump stage 1 and 2. Do y'all remember that?
Yes.
GOG 175, 157.
Yes.
The stage 2 tumors, had a recurrence rate that was
Very high.
what was it, like 40 to 50%?
Yes, it was very high. I was
Very
surprised
high.
to see that data.
Yeah, so so I absolutely do use it when I have someone that's quote unquote stage 2. I've actually even used it in stage 1 BRCA with a lot of counseling. I do think to myself whether or not they need the full 2 years of PARP inhibitor. I could do 1 year, but completely making that up. I do 2, but they might only need 1. But I do a lot of counseling around it with patients because we don't have any data and we will never have data. And so you have to make decisions. But Dr. Elizabeth Swisher at University of Washington has published in the past data, and it's retrospective, like all things in this early stage population, but the patients with early, like stage 1 serous tumors that are BRCA versus not BRCA, the BRCA tumors, those patients recur at a much higher rate than the stage 1 non-BRCA that are probably cured with surgery,
Yeah.
And that makes sense because if you have a germline BRCA, it's a field effect, right? The peritoneum is impacted. There's probably other things. So what is their true recurrence risk? Maybe it's 20% or 30%. We don't
That's
know.
still
We
high.
never will.
That's
But
still high.
it's still high. And
That's
so
still high, yeah.
I do talk to patients about PARP. Most patients want it, and they understand the risks, and we talk about it. So I do both. But I will acknowledge there's no data for it, and
There's no data as of now. Yes.
fight with to get the drug, but I always win. I always get it.
So
But
based on Solo 1 data, we know that if you look at the Kaplan-Meier curves, 20% of patients are actually relapsing within the first couple of months of completing their platinum-based chemotherapy. And this is, of course, the control arm of the study. And these are considered to be patients who are platinum resistant. And so they wouldn't be eligible for a PARP at the time of relapse. And then you've got those platinum-sensitive patients from the control arm, where we know that when you give them chemotherapy, 20 to 40% of these patients are not going to actually respond to chemo. And again, they will not be eligible for a PARP inhibitor. And so in my mind, the best time to give a PARP is in that first line setting. So the next voting question, in the setting of a BRCA mutation, do you believe all PARP inhibitors are the same? Dr. Hala, do you believe that all PARP inhibitors are the same? So whether you give olaparib or niraparib or rucaparib, in the setting of a BRCA mutation, do you believe all of them are the same?
I think yes. I think in the BFS results that we can see that there is yes somehow that the same in the result, but of course that for the overall survival we can see only that's in the olaparib.
Okay, Dr. Ahmed Shams, what are your thoughts here? Do you think that all 3 or all the PARP inhibitors are the same in this setting? You're muted. You're muted, Dr. Ahmed.
Yeah, I think I'm agree with Dr. Hala. I think it's the same. Yes.
All right, so this lady has upfront surgery with optimal debulking, as I said earlier on. She's found to have a somatic BRCA mutation. So my question to you, Dr. Aref, in the setting of a BRCA mutation, doesn't matter if it's germline, doesn't matter if it's somatic, do you prefer giving a PARP inhibitor alone or PARP plus BEV? Remember, we have data for PARP inhibitor alone. We have data for the Paolo, which tells us you can give BEV plus PARP. What are your thoughts here? What would you give in the maintenance setting for this particular patient?
Yeah, for this particular patient, if she is BRCA, I will think to go for solo one pathway. But if she's a high risk, for example, there is a residual disease after the upfront surgery, so she is a high risk, maybe I will add BEVA because there is a residual disease. So she will be BEVA OLA, not because I decided to go in Paula one pathway, but because of this residual disease. And she's a high risk, so I will add BEVA plus OLA in this situation if there is residual disease. If no residual disease, it will be solo one pathway.
So I just want to remind people of this propensity score matched analysis that was presented at the SGO a couple of years ago and then finally published, I think, in CCR, which I actually think is an interesting hypothesis generating paper, which actually took patients from Paolo, took patients from Solo, matched them, and found that olaparib plus BEV was superior to olaparib. So Kathleen, I'm going to ask you two questions over here. My first question is a patient with advanced ovarian cancer who has a germline mutation BRCA the same as that patient who's got a somatic BRCA in terms of, like you said, field cancerization and all sorts of other things in terms of also response to treatment? And what are your thoughts about this propensity score matched analysis? I have to say, even before this was published, I was a big fan of Paolo and I liked giving olaparib plus BEV because in our part of the world, we do see a lot of patients, despite giving them BEV with the chemotherapy, and then they get surgery, we used to see a lot of residual disease. And I felt that these were super high-risk patients where I wanted to give something extra. So what are your thoughts here about these two questions?
Yeah, so this analysis, so I was involved in this analysis, just so everyone knows, so there's a little bit of COI.
Bias.
So I like it a lot.
Yes, so do I. So do
like it a
I.
lot. So, but I do like it a lot. But we also just have to say up front that it is not clinical. It's not a clinical trial, and it is an exploratory analysis. So there's a lot of bias here, but it is a really nice analysis because unlike other attempts by other companies or even AstraZeneca to do these sorts of comparisons where they have the Kaplan-Meier curve from, say, GSK study or Clovis, and then they compare it. Here, because both of these studies were AstraZeneca supported, we had the individual patient data to put into the database. So that's a little different than kind of most comparative analyses, because we went back and pulled all the patients from Paolo 1, individual patient data, and then we pulled from Solo 1, from the olaparib arm, patients who, this is where the propensity weighted match came in, patients who sort of looked like the population that was enrolled to Paula. Paula, when you look at the populations, was a little higher clinical risk. There were more stage 4. There was more neoadjuvant. There was more partial responses than in Solo 1. Solo 1 was kind of a remarkable population in that it was largely stage 3, primary cytoreduction, no gross residual. It was like the best prognostic, and all BRCA, best prognostic group you could ever look at. So Paolo 1 wasn't that. So you couldn't just pull the olaparib patients into this like they're all the same patients. So that's where the propensity weighted matching came in. So it is a very nice statistical analysis, but take it with a grain of salt. What this shows you is that in that analysis, that olaparib BEV is better than olaparib, but the degree it's better is the same degree that progression-free survival is improved in every study of bevacizumab. You know, it's about a 30% improvement
Exactly.
in the PFS. So the rate of progression events decreases by 30% when you add BEV. So there's no synergy. There's I would say there's not even additivity here. It's independent drug effect of olaparib bev. And that's important to say out loud. I like olaparib bev too. I mean, I think prolonging the progression-free survival is good for a patient. But I have a lot of patients that just don't tolerate bev, like their blood pressure is huge or they get joint pain or whatever. So if I can't use it, I don't feel like I'm hurting someone's like long-term survival. And so you really have to decide if you've started bev and your patient's doing fine, I'm going to use a Palo regimen. I'm not going to think about anything else. If I've started bev and they're doing fine, I'm using Palo, period. Somatic BRCA, germline BRCA, HRD, that's how I think. I'm not more inclined to use Paula because of those things. I've made my decision for bevacizumab early on, and then I'm just going to continue it. But if the patient's doing poorly with bev, which sometimes they do, I don't feel bad about dropping the bev.
So let me ask you this question, Kathleen, since you were involved in this study. I mean, now we have the overall survival data for the 2 trials. Why hasn't this data been updated to look at overall survival as well and do that propensity score matched analysis, but looking at OS?
I've actually never asked them to do that. This was driven by Ignace Verhote, who is the lead. I've never asked him to do that. I'll ask him.
Yeah.
Why not?
Ask him and then let me know.
We should do it. I actually didn't even occur to me to update this. Because we're getting close to, hopefully we're going to be able to call OS on, we don't have OS on Solo 1 yet. That's why. I mean, that's A, we haven't asked, but B, the other reason is AstraZeneca has been pretty conservative about any sorts of exploratory analyses outside of this. This was a rare one from Solo 1 because we haven't reached OS yet, and OS was a agreed upon endpoint with the US FDA, and they don't like to go into the data, to do extra things until the study's met its endpoints. So that's kind of one of the big reasons. So we wouldn't be able to do that OS look until we agree that we're done following OS in Solo 1. And we're 10 plus years out now, if that gives you any indication of how well these patients are doing.
And would you at all consider, and again, this is just something that I've been thinking about for a long period of time, looking at those groups of patients, because you've got such long follow-up, who've perhaps crossed the 5 or 10-year mark, and then checking to see who are those patients that you can get that long-term survival for, in terms of, is it better with olaparib plus bev versus olaparib is a question I'm trying to ask in terms of the long-term responders or the long-term survivors.
There's a lot of interest in that, trying to figure out. So I think once we do reach OS for olaparib for Solo, there may be the opportunities to do this. There's a lot of interest in modeling whether or not we can sort of forecast, like at 5 years is too short. If you're disease-free at 5 years, of course we love that, and that's amazing. But it's too short. You can't look at that and go, your likelihood of being alive at 10 years without disease is X, because we still see these recurrences. Probably the earliest we can call it is about 7 years. But we've really never looked at it in a BRCA population and an HRD plus minus BRCA and not. So there's a lot of interest in trying to figure out if you could do landmark sorts of assessments in these studies to predict who's cured or not. And I think it's probably going to be something that's still a few more years out.
Yeah, I can imagine that if you had access to all the data from Solo and Paulo, you could potentially develop some sort of, like you said, a modeling app or something that you can actually plug in the characteristics of the patient that could help you actually determine whether you should give them BEV or not. And I think that would be something very
that
cool.
would be key. Exactly. If you could say that and you knew you were treating, like there was data, we just got back from the Society of Gyn-Onc. It's actually still going on today. I came home last night, but there was an interesting presentation on out of MD Anderson where they were doing second look laparoscopy at the end of chemo, which we used to do like when I was a very young person. Remember, we used to do that. We'd do a second look like laparotomy at the end of chemo, and then we'd find cancer in like 50% of people that were, NED, and then you couldn't do anything about it. So it didn't impact how people did, and so we stopped doing it because why do that to a patient? That's mean. But they've started re-looking at this with laparoscopy and then trying to figure out, and ctDNA, to see if they can now escalate. Should they use PARP-BEV? Should they use an immune checkpoint inhibitor? Should they use an antibody drug conjugate? Is there something we can do there at that point where there's no measurable disease, CO125 is normal, CT looks normal, but we know there's cancer there. Is there something we can do, to wipe it out so that maybe that patient doesn't recur? We don't know, but there was some interesting data starting to look at this with ctDNA, and I don't know that BEV's gonna fix it though. That's kind of a big ask of bevacizumab, but something else might. To your point, like
Yeah.
who should I leave alone and let her have a nice life?
Perhaps it's the era of using targeted therapy in those patients who've got that residual disease once you've done the scope, and you do those biopsies and you see maybe using an ADC or something like that. Now, in the last 10 minutes, I want to go through this algorithm for the NCCN guidelines because, as you know, it's just been updated in 2026. So, Sina, maybe I can start off with you. If you have a patient with a germline or a somatic BRCA1, BRCA2 mutation, just like the case I've just presented to you, what would you like to give? The NCCN actually gives you the choice of using either BEV with either of the 3 PARP inhibitors, or BEV. If BEV is not used, you can just use olaparib or niraparib. So what is your typical usage in the clinic if you have a patient with a BRCA mutation?
You mean no neoadjuvant treatment, just primary surgery and adjuvant?
I'm looking at the maintenance setting. What would you like to use in the maintenance setting? What do you typically tend to use in the maintenance setting?
Like Dr. Aref said, if there is residual and it is not optimal surgery, I would add bevacizumab for sure to olaparib. But it is optimal and BRCA mutation is obvious, then I can go with monotherapy olaparib actually.
Perfect. Dr. Ahmed, what would you do in a patient with a BRCA1 or a BRCA2 mutation in your clinic? What do you typically tend to do for these stage 3, stage 4 patients? Dr. Ahmed, if you can unmute yourself.
Yes, if we are talking at the same situation in germline, in somatic BRCA1 and 2 pathogenic, we are usually give olaparib and keep BEV for later on.
Okay. Kathleen, very quickly, any difference in your practice between a somatic and a germline BRCA, or do you treat them all the same?
I treat them all the same.
Okay, perfect.
I treat them, I don't differ based on that. It's all based on clinical factors, and other things, but they're all getting a PARP plus BEV. My decision isn't based on somatic or germline.
Okay. Dr. Aref, now what if this patient had HRD deficient disease but was BRCA wild type? What do you typically tend to do for these patients in your clinic? First of all, do you use bevacizumab? And 2, do you use BEV plus a PARP, or will you use PARP alone?
Yeah, for patient, if she's HRD, I will go to Paula-1 pathway. So I will use Beva.
So you're a big fan of Paulo. You're my friend. I like Paulo a lot. I do Paulo
I'm your friend. But another thing, if there is contraindication for bevacizumab,
that's different.
We remember that PRIMA study, all patients are high risk, all with residual disease. So niraparib indication in patient with residual disease, this is the fit patient for PRIMA. So if your patient has a residual disease and you don't want to give beva-ola, give niraparib and follow a PRIMA pathway, and you are in the right trial for that.
But you can use also olaparib on its own. I mean, Kathleen, we have actually, this was something that was added, I think, in something that was added in the 2026 guidelines, although the data for me is not very clear, where they're saying that if you don't use bevacizumab, you can actually just use olaparib on its own, although the data for that really comes from niraparib and rucaparib, not really olaparib. So what are your thoughts here about using olaparib on its own in patients who are HRD deficient BRCA wild type?
Oh, I use olaparib. I just do. And again, I've done all this stuff with AstraZeneca, so I'm probably really conflicted. So I'm just going to say COI alert for me personally. Okay. But I use olaparib. I just think it's the best tolerated PARP. Niraparib, I don't hate niraparib, but just the thrombocytopenia is just so hard, to navigate
it's hard to
instruments.
manage
I've
that
had
side.
patients with like 1 platelet, and the weekly labs, and really having to now to do that with olaparib. So there's no hypertension, there's no palpitation. So for me, it's just an easier to use option, and that's what I use. And now that it's on NCCN, it's it's super easy. And there's a study ongoing called Mono-Ola that I think is going to definitively show its efficacy, so people can use it globally. But that's what I use.
What are your thoughts here on the fact that the NCCN investigators or authors actually put bevacizumab as monotherapy as a maintenance strategy in patients with HRD deficient disease? It's clearly inferior.
It's
So
clearly
why
inferior.
why would they even give that option?
I don't know. I don't understand the majority of things that the NCCN does, and I mean, I just don't understand it, because there are people, just speaking in the US, the majority of patients are taken care of by medical oncologists in the community who take care of every cancer. And I don't know how they keep up. Like, it's just amazing to me. But, if you only are taking care of a few patients with ovarian cancer, I just don't know how they would keep up with the nuances of this disease to understand. And they go by the NCCN, like that's their guide for what's available in each line of therapy. So if these are presented as equivalent options, then, patients have the risk of being inappropriately treated, because these are not equivalent options at all. So it really kind of makes me angry. I don't know why the NCCN does what they do. I mean, just as another example, the NCCN had on for low-grade serous ovarian cancers for years, they had a listing for letrozole instead of chemo in the front line based on retrospective data only. Retrospective data only. It's been on there for years. It's like an okay thing to do. And we just saw data 2 days ago at SGO, phase 3. It's inferior to chemo letrozole. It's inferior. And it's been on the NCCN for years. So patients have been getting inferior treatment for years, because of course they want letrozole instead of chemo letrozole. Like, who wouldn't want that? That's what patients want, but they also don't want things that are inferior. So the NCCN, I have a love-hate relationship with.
So, Dr. Hala, what would you do in a patient who is HR deficient BRCA wild type?
Deficient BRCA wild type, we will
Yes,
add yes, I will add, if the patient is receiving bevacizumab, I will put in the maintenance beva and olaparib.
All right. So I think
Yes.
if I could just ask Dima the question before we end, because we've got literally 2 minutes. What is your favorite PARP inhibitor to use? Say, suppose you're using a PARP inhibitor, which is your favorite PARP inhibitor to use in a patient that's BRCA wild type HRD deficient?
So for as we know, for the BRCA mutated, we have, I prefer olaparib. We have overall survival data. I like the Paula, like you said. I would love to combine it. Now, when it's HRD positive, then olaparib and niraparib are comparable. Now, this is 2 years, this is 3 years. You have to discuss it with the patient based on side effect, as well as their platelets is like in their 80s or 90, or, it depends on the side effect profile. Comparable, however, I tend to use olaparib because I started use olaparib before the niraparib long time ago. So we are creature of habit. We like to use things that we used before. I've had niraparib in a few of my patients, especially when this all-comer study came, but now we're again more toward olaparib.
So, Kathleen, you have the last word in the last minute. Should anyone be using any type of PARP inhibitor in those patients, HRD wild type and BRCA wild type? Should any of them be getting a PARP inhibitor?
So the difficult answer to that is probably yes, because HRD as a test is really imperfect. And there are tumors that are called HRD test negative that do have vulnerabilities to how they fix their DNA and do benefit from PARP inhibitors probably pretty well. It's probably just a minority of them. And so, when we had the all-comer approval, and you had a patient getting neoadjuvant, for example, and the tumor just melts, and at interval surgery, there's no tumor, and their KLIM is favorable, and their HRD test negative, I don't care. I'm going to use a PARP inhibitor because that tumor has already told me that it has vulnerabilities and how it fixes DNA by virtue of the fact that it responded to platinum so well. And so I would have used it there. So losing that opportunity for patients there bugs me a lot, but the majority of patients don't benefit. And we just need to start focusing on why those tumors are good at fixing their DNA. Cyclin E amplification is one. We have CDK2 inhibitors moving into the space. Will they work? We will see. But that makes a lot of sense. Like, let's figure out why these tumors are just so bad and write trials for that. Write trials for MYC, write trials for whatever, rather than just trying to treat people with PARP just because we have it. And I think that's just the reality. So I don't hate that we lost the approval in the US, except I hate the fact that we lost the ability to be physicians and individualize for patients and make good choices. But I think the majority of patients were just getting harmed with PARPs in that setting. And so I don't think it's a terrible thing.
So we've reached the top of the hour. I'm 1 minute above time, so I apologize for that. It has been a brilliant roundtable discussion. I had so many more questions, but we obviously were short of time. You all have been super, super brilliant. Thank you, Kathleen. You were awesome. Thank you, Aref, Ahmed,
Thank
Dima,
you.
Hala,
Thank you.
and Sinam. You all have been, and Ahmed, you all have been super awesome. And I hope to see you at the next edition of the EIOC Journal Club. Take care and stay safe.
Thank
Bye,
you.
everybody.
Thank you.
Bye-bye.
Thank
Have a
you.
good
Thank you so much.
Bye.
Good
Bye.
night. Stay
Good
safe.
night.
Good night.
Take care.
Bye-bye.
Bye bye.
Bye.
By beef here.